I'll be, Professor Jan will be setting up his talk on the other computer. There was some technical hitch. So I'll proceed with my talk, which is on ray tracing aberrometry for corneal and lens-based refractive surgery. So now this is what the eye trace looks like. And what is it? It is basically, it's a placido-based topography, and at the same time, there is an aberrometer, right? So it provides us with auto-refraction, it provides us with the keratometry, placido-based corneal topography. It also does ray tracing aberrometry and does the pupillometry in these patients. So what is the advantage of an eye trace? So what it does is it fires 64 spots 4 times to gain 256 spots, right? And this is used to generate what is known as the retinal spot diagram or the point spread function in these patients. So all the data, the quantitative and qualitative data that you are getting is derived from this retinal spot diagram and point spread function. And since the patient is looking at a target which is distant with the relaxed accommodation, the measurements and the values we get are a lot more physiological than with other machines. So now, just a word about other machines like the Hartmann Shack aberrometer or Scherning aberrometer or the skioscopy-based OPD scans. What they have is, there's a fixed signal which goes into the eye and fixed signal which comes out. So there are some inaccuracies which can come in, something known as the crossover effect can come, or there can be some duplication of spots. So that can actually, especially in complicated eyes, it can lead to a problem in the data that you collect. What the ray tracing does is, it fires individual spots and individually they are analyzed. So therefore, the data which we get is far more accurate and it does not suffer from the inaccuracies of the data collected. Now, what all can the eye trace do for us? One, it can help us in the preoperative planning of the patient, okay, both for cataract and refractive surgery. And most important question, does the patient need cataract surgery? Patient comes to you, he has a 6/9 vision or 6/6 vision. Does he need cataract surgery? This can help you decide that. It can help us in diagnosing certain lenticular pathologies. It can help us in assessing the visual outcomes. It can help us in planning the toric IOLs. It can also help us in deciding whether the refractive complicated patient with residual error, does he need enhancement or can we just leave him alone? And most important, is this patient a good candidate for multifocal intraocular lenses? So I'll just be going through them in the next 10 minutes or so. So what program do we use to decide to do the preoperative planning? We use the topography, we use the aberrometry, right? So it starts with the data verification. So the good part about this machine is you can see how accurate is your data and how reliable is it to plan your surgery. So a quick assessment can be done, and at the same time, it gives a nice overview. This is a tracy refraction which has been shown to be very accurate when compared to a manifest refraction, and also gives us the RMS values of the higher order revisions of the eye. Next, we move on to something known as a wavefront display. Now, many of us, we don't want to go into figures. We just look at what is going on. So when we look at this map, this is not a topography map, it is actually a map of the wavefronts. And this look gives us just a qualitative kind of a look. So when we see these kind of colors, we know that there is something wrong with this eye and we should look more closely at this eye. And when we look at the Chang analysis, so one was the wavefront analysis, we have gone into the Chang analysis. So this gives us a more quantitative. So when we want to look closely at any of the errors, so what it does is it will automatically show up that these values are significant in these patients. So this will quantitate the whole thing. So this also helps us in planning the surgery of these patients. Now, does the patient need cataract surgery? So this involves grading of the cataract and DLI. We know we rely on LOX grading. LOX grading is also, although you're comparing with photograph, it can be subjective at times and can have errors. So look at this patient, 6/6, complaining of diplopia, dissatisfied with vision, even after glasses. What do you do with such a patient? So this is not from this patient, but it shows us there's something known as an opacity grading. So this opacity grading is generated in the eye trace. Now, this grades are, it may be 1 or 0, 2.5, 4, whatever it is. They say that if the value is more than 2.5, we can be reasonably certain that if we take out the cataract, this patient is going to be happy and he's going to see well after surgery. It's a very big thing when we are planning surgery in these patients. The something else that it gives us is known as dysfunctional lens index. So what is that? It is calculated based on, very complex formula, which is a secret by the company, higher order aberrations, visual acuity, contrast sensitivity. Basically, it's a numerical value which tells us of the visual performance of the lens. That's it. And so just imagine that you have a number which comes and okay, fine, is the lens possible that the lens is causing these problems? For example, in this patient is 2.97. So any DLI which is less than 5, 10 is 0, I mean absolutely normal vision. So less than 5 is considered to be visually significant. Then we move on to diagnosing lenticular pathologies and assessing visual outcomes in patients of surgery. So one, we have something known as a vision simulator. So patient comes to us, has a cataract. For the doctor also, it's so much easier to show this to the patient and say, listen, I understand your problem and probably this is what you're looking at. It's remarkably accurate, what it generates. So this is the kind of simulator that is available on the eye trace. So this patient was a 21-year-old lady who came for refractive surgery. Now we're just going to look at the eye trace map. So the corneal eye trace map is normal. It also gives something known as the internal or the lenticular maps. So this was hazy. And when we move on, we see, again, I'm going back to the Chang analysis, and Chang analysis shows us that this internal means probably something in the vitreous or the lens. So this internal means there was significant aberrations which were there, which were not associated with the cornea. Cornea showed a astigmatism, and we know that astigmatism we can correct with the refractive surgery. And sure enough, this patient had a lenticular coloboma. Again, just to revise, you can see the wavefront map. Cornea is all green, means normal. This is rainbow colors. Immediately as you look at it, you'll realize that something is wrong with the lens. I need to dilate, take a close look at this patient. Even PCO, we have to decide, does the patient need a YAG or not? We know that YAG capsulotomy can have a problem. We don't want to do it left, right, and center in patients. And again, both the DLI becomes significant and both the simulation chart becomes significant. These patients, once we do a YAG capsulotomy, see perfectly well. Patients of scleral fixated IOLs, just a patient showing dissatisfied with vision, and just by doing the eye trace, we can see that the patient has a significant coma and patient had a lens tilt, which was causing the astigmatism. Toric IOLs, I'll not be going into detail because of the lack of time, but it does have a toric planning system, including the Zaldivar calipers, and even for misaligned toric IOLs, it's very good to help us to align the lens in the correct direction. Now, whether a patient needs an enhancement or not, this is something known as an MTF. So MTF is basically, it's again a numerical way of measuring the contrast sensitivity. We know how painful it is for the patient to measure the contrast sensitivity in a patient. Here, within 2 seconds, you are getting the reading. And what it shows is, if you see the red box, which corresponds to 40% of contrast versus 10 cycles per degree of the spatial frequency, any reading above this is considered to be okay, normal. And if it dips like that, it means it is there's something wrong with it. So in this patient post LASIK surgery, there was a little dip, and this patient was not satisfied. The patient underwent an enhancement of LASIK, and then this is the preoperative and this is the postoperative vision, and tracy refraction is almost normal. The aberrations were also within normal limits. So this is how the contrast or the modulation transfer function improved in this patient after surgery. So in the end, is the patient a good candidate for multifocal IOLs or not? So what it does is, the eye test gives us angle, kappa and alpha. Now kappa we know is visual axis to the pupillary center, and if it's too decentered, we know that he's not a good candidate for premium IOLs. And same with angle alpha, it's how well does the bag fit with respect to the pupil. And basically it's a visual axis to limbus. It's measured from the limbus, and it gives a so if it's more than 0.5, either of the values, you should be very cautious in planning multifocal surgery in this patient. So just a simple algorithm for IOL selection using eye trace. So perform the eye trace for multifocal IOLs I'm talking about. Perform the eye trace, assess angle alpha kappa. And if the kappa is more than 0.5, plan a multifocal IOL. If the kappa is less than 0.5, what we do is we look at the Chang analysis. Now, we consider corneal aberrations of 0.14 or more or less to be significant. So, if it is corneal aberrations are more than 0.14, we should go for monofocal IOL. And if it is less than 0.14, we can plan for either toric, multifocal or other premium IOLs like enhanced monofocal lenses. So it also gives us an IOL selection analysis. If you really don't want to remember too many figures or something like that, it just gives us this little box here. And you can see in this box, is the tracy refraction normal? Yes or no? Are the corneal higher order aberrations present? No. And internal aberration, higher order aberrations present? Yes. This is because of cataract. And if the cornea is not abnormal, it recommends that you can go in for a premium intraocular lens in this patient. So just to conclude, a 2020 unhappy patient is unacceptable in the 21st century. And then in this new era of cataract and refractive surgery, I think the eye trace is an invaluable tool, not only in the surgical planning, but also in communicating, teaching the patient what is there. We understand his problem. Most of the patients are very satisfied to see, yes, they come with diplopia, although they have a cataract. There was a patient who was advised a CT scan, but just had a cataract, and we diagnosed it with also aided by the eye trace. And it also helps us to understand the outcomes of surgery better.